Okay, so we have introduced ourselves as clinicians. I've talked about how to use the course, and I've given you an overview of how IBD happens. Now I want to talk about what it means to me to take a science-based approach to helping people with inflammatory bowel disease. So to do that, I'm going to give you a very brief history of medicine and of science, and then I'm going to talk about healthcare statistics. And statistics can be hard, but I'm going to try and make it easy and really, really relevant to inflammatory bowel disease. So broadly speaking, in the history of medicine, there was wartime medicine, mostly dominated by men, and it was all about fixing acute problems quickly. And then there was peacetime medicine, herbalism, midwifery, that type of thing, mostly dominated by women, and that had a focus on promoting health over the long term and minimizing side effects, that kind of thing. And it's pretty reasonable to say that our modern healthcare system of conventional medicine, drugs, and surgery is mostly descended from this history of wartime medicine, which has some real good strengths and some weaknesses. And naturopathic medicine and many of our other world medicines like Ayurveda and Chinese and East Asian medicines, acupuncture, that kind of thing, are more descended from the peacetime history of medicine, and has its own advantages and disadvantages as well. So we had these different medical systems going on for a long time, and 100, 150 years ago in the United States, there were a lot of different medical schools. There were conventional medical schools, and there were naturopathic medical schools, and there were osteopathic and chiropractic medical schools, and they all had different focuses and different lengths of time. And this doc named Flexner went around the United States evaluating the quality of education in different medical schools around the country. And in 1910 issued the Flexner Report, which basically said most medical schools out there are crap. They're night schools. They don't have the right amount of equipment. They don't teach people for very long. And Flexner said, look to Maryland, to Johns Hopkins University, that has a 4-year program with didactic, that means classroom-based, and clinical components, and they're using microscopes and dissecting cadavers, and 4 years is long enough to be a doctor. And all other programs should aspire to that kind of quality at Johns Hopkins in Maryland or close down. And so there was this interesting process where a lot of schools closed down. A lot of conventional medical programs closed down, and a lot of naturopathic and other programs closed down. So putting into that history there, my great-grandfather, Michael Nestor, actually went to University of Maryland Medical School and graduated in 1906. He started in 1905. His entire medical school experience to be a conventional MD doctor back in 1906 was a 6-month program, and then he stuck around and did a 1-year residency, and then he went back to Rhode Island and practiced as a doctor and a public health official for the rest of his life. That's what things were like before the Flexner Report. Now, when his son, my grandfather, Dr. Thomas Nestor, left Rhode Island and came down to University of Maryland Medical School to get his MD, in 1936, that was after the Flexner Report. So at that point, medical school was a 4-year program with a classroom or didactic portion and a clinical portion and cadaver dissection and microscopes and histology and all of that stuff. So really, medical education changed dramatically during that time. Now, in 1901, Dr. Lust founded the American School of Naturopathy in New York. And that was the first naturopathic medical school in the world, 1901, before the Flexner Report. Now, most of the naturopathic medical programs closed down after the Flexner Report because they weren't sufficient enough. But the oldest continuously operating naturopathic medical school in the United States today is my alma mater, National University of Natural Medicine, which opened in 1956. And to attend NUNM, you have to take prereqs. You have to have an undergraduate degree with the regular pre-med courses, chemistry and biology and organic chemistry and all those things that you have to take to get into any medical school. And then it is a 4-year doctoral or professional level training program with over 4,000 hours. There are didactic or classroom and clinical components. And then once you graduate and you take the national licensing exam, the NCLEX, you pass boards, you can become a licensed naturopathic doctor. And your scope of practice varies from state to state. For example, in Oregon or California or Vermont or Arizona or Hawaii, broad prescriptive scope to prescribe any drugs you need for a primary care practice. In many states, we can do minor surgeries and also do low velocity, high amplitude type manipulations like chiropractors do. In other states like Colorado or Maryland, we have no prescriptive rights, or in certain states you can't do certain types of manipulative therapy, or you can't do minor surgery, that type of thing. So scope of practice varies a lot state to state about what is the scope of practice a naturopathic doctor can have in that state. And we do have certain fellowships, like there are oncology fellowships, and I mentioned I'm a fellow of the American Board of Naturopathic Gastroenterology, letting you know that I have passed a board exam to be a gastroenterological specialist. So a couple other things that distinguish naturopathic medicine. One is, here are the 6 pillars of naturopathic medicine, and they're very, very similar to the pillars of conventional medicine. We also take a version of the Hippocratic Oath, which says things like, first, do no harm, primum non nocere. Identify the cause, treat the whole person. A doctor should be a teacher. We should try to prevent harm. And we have this one that is kind of unique to naturopathic medicine, which says, tune into the healing power of nature. Use nature as your ally instead of trying to fight nature as you're using medicines. Another thing that distinguishes us is what's called the therapeutic order. And the therapeutic order says, work at whatever level the patient needs, but the lower down on the therapeutic order you can work, the more likely you are to build a foundation for long-lasting health. So it's going to be hard to maintain long-lasting health if you haven't established the foundations for optimal health, identifying and removing obstacles to cure, and assessing the determinants of health. How is somebody's diet? How is their sleep? How is the air they're breathing? Are they staying hydrated? Are they moving their bodies? Those are the types of determinants of health. But at some points, we might need our highest forced interventions, emergency surgeries, the most powerful and potentially even toxic drugs that we have just to save a life. So this is the therapeutic order, and this is somewhat unique to naturopathic medicine. And I just want to make one brief case that we'll be talking a lot about research, and I love research, as you'll come to know, and so do my colleagues, Drs. Sheeler and Bustamante. But there's a lot about naturopathic medicine that has not been studied. So we don't have high-level evidence about how well it works. And the reason is that natural products are very hard to patent. And so money drives research. If you can make a lot of money off of a drug, it makes financial sense to invest money in researching how well that drug works. And so we have a lot more research on drugs that can be sold for a high profit because they can be patented versus natural items, a lot less research. And frankly, in this world we live in, there is never going to be as much research on natural therapies. So we're left using different clinical traditions to assess how well our therapies work. And I'll talk about that in a moment in my history of science. So when we talk about the history of science, we're talking about medical science in particular. We're talking about how well we can assess if a therapy works or how well it works. And sometimes I say the history of medicine is the history of expert opinion. Well, my teacher taught me to heal people this way because her teacher taught her to heal people that way, because her teacher taught people to heal people that way. So this long history of expert opinion. I've healed people for however many decades now. I'm going to teach you the ways that I saw work in my practice. So that's great. And a lot of our data from naturopathic medicine is still at this level of expert opinion. And also, I think it's true and accurate to say that in certain specialties of conventional medicine, most of the evidence is expert opinion as well. Surgery, for example, most of it has not been studied to randomized controlled trials or meta-analyses. Most of surgical medicine is expert opinion. And obstetric medicine, how to properly do childbirth. Most of that as well is expert opinion. So there are other medical fields that do also a lot of good work in the world where we don't have a lot of high level on this pyramid evidence. But the more high on the pyramid you get, the more trustworthy the evidence is. So if you have case-controlled studies or cohort studies, or if you have randomized placebo-controlled trials, that gets more believable. And then if you have meta-analyses or systematic reviews of multiple randomized controlled trials, well, that is even better. And then once you've got a few meta-analyses out there, in conventional medicine, often there are clinical practice guidelines released saying we think everyone should practice this way. So the way we practice naturopathic medicine, there are not very many clinical practice guidelines in naturopathic medicine. When they do exist, or even when they exist in conventional medicine, we pay a lot of attention to them and we follow them because that is amazing evidence out there. But when we don't have clinical practice guidelines, we look to meta-analysis whenever we can. We'll be presenting a lot of different meta-analyses in this course. And then we look to randomized controlled trials and cohort studies, case control. We really are trying to bring in every level of evidence that we can to understand what could help you the most. A couple of historical slides on healthcare statistics. So I won't read this whole quote to you, but in the 1600s, this doctor really kind of proposed one of the first randomized controlled trials. He never actually completed it, but this is one of the first historical references to a randomized controlled trial. This guy also thought if you put basil between two bricks and put it in the sun, it would become a scorpion. So, you know, he didn't have the last word on how to conduct medical science. And really, when we get into the 1920s, there was an amazingly influential statistician named Ronald Fisher. He had some funny ideas too, but he may be the most cited person in all of medical science and came up with a lot of basic statistical tests that we use today. He actually has a couple of statistical tests named after him. And there was this incident that he wrote about that happened to him in about 1920. Where he was talking to a couple of colleagues, scientist colleagues, and he offered to bring a cup of tea to one of them. And she said, no, because you've already poured the milk. And I like adding tea and then the milk afterwards. I like the taste better. Well, Dr. Fisher said, no, there can't possibly be a difference. And the other colleague that were there, actually the two colleagues who were with ended up getting married to each other. They said, well, let's do a test. And they came up with this idea where they would pour 8 cups of tea. And in 4 of them, they would add the milk first. And in 4, they would add the milk afterwards. And Fisher brought out the cups of tea to his colleague in a random order. And indeed, she did identify all 8 of them correctly, whether the milk had been added first or the milk had been added afterwards. And so Fisher came up with this idea that if you can identify something correctly, that you would only be able to identify by chance 5% of the time, well, that is probably statistically significant. So he said, let's talk about a probability value or p-value. If it's less than 0.05, so less than a 5% chance you would be able to guess that correctly by accident, that is statistically significant. And that's the value we use to this day. Now, this is not universally true. It's not like if you could only guess something correctly 6% of the time, that it's totally bullshit and it's not actually statistically important. Or if you could guess it 4% of the time, now it's magically super much more important. We do use this threshold, and you will see authors in scientific papers all the time say, it reached statistical significance. But I'll look at a paper where the p-value is 0.06, not quite statistically significant, and I'll still think, okay, there are ways where this could be important to my patient. So if you hear us talk about p-values or you see this in scientific papers we present, that is what we're talking about. I want to talk about a super important concept, which is absolute risk versus relative risk. This idea is super important for health literacy and for understanding healthcare reporting. I'm going to mention a couple of different examples. So here is one. What is the risk of getting Crohn's disease if you have a first-degree relative who has Crohn's disease, or you don't, if you're just part of the general population. So you can see that general population versus first-degree people with a first-degree relative who have Crohn's, you're like, oh my gosh, look, there's like a 35-fold risk. That's amazing. That's super high. But if you look at that in terms of what the actual risk is, the risk to the general population is so low that a first-degree relative of someone with Crohn's really only has about a 10% risk of getting Crohn's. So it looks gigantic when you think about relative risk. But if you think about absolute risk, it's still important, but it's not gigantic. Here's another great example. And this is about a type of treatment for IBD, which Dr. Sheeler will talk about a lot in the drug section, called thiopurines. And there's a risk of getting lymphoma, elevated risk of getting lymphoma if you take thiopurines for your inflammatory bowel disease. So here's the risk of somebody in the general population and of getting lymphoma. And here is the risk of somebody with IBD who takes thiopurines. So you're like, oh my gosh, it's 4-fold risk. That's hugely elevated and worrisome. And it is statistically significant, has a p-value of less than 0.05. But if you look at the absolute risk in the general population versus somebody with IBD taking thiopurines, you're like, okay, it's only a 0.002% risk versus a 0.008% risk. So if you look at that, considering everybody's risk of getting it, that means the baseline population has a 99.998% chance of not getting lymphoma, and somebody with IBD who takes thiopurines has a 99.992% chance of not getting lymphoma. So it's statistically significant, and we think about it for good reasons, but I don't want people to get too worried about it because the absolute increased risk is very low. Here is another important statistical idea, which is regression to the mean and the placebo effect. So I want to talk about a drug called adalimumab, which is when it's used for ulcerative colitis. So here are the clinical response and clinical remission rates. So people with ulcerative colitis who take adalimumab, that's also known as Humira, have about a 50% chance of having a response. That means that their score on one of the validated scales has decreased by a certain number of points. So a 50% response, not bad. And a 15% chance of going into clinical remission. So that's pretty good. However, if you look at the placebo effect, people in these same clinical trials who were on placebo instead of adalimumab had a significant chance of having a response or entering clinical remission also. Part of that might be the placebo response. That is to say, they knew they were getting maybe getting an IV medicine and their brain made changes in their physiology which led to them improving. And it could have to do with what's called regression to the mean. Regression to the mean means people with IBD fluctuate. So some of them are getting better and some of them are getting worse. And some of these people would have been getting better no matter what. So if you look at the benefit of adalimumab or Humira, that's greater than the placebo response. It means about 13% of people are getting a response and about 7% of people are going into remission. Now, I have seen this drug help people and I think it's worthwhile to try using, but you've got to put things into the context of knowing not just what the overall response is, but what the overall response is as compared to placebo. There's this idea of evidence-based medicine, and I called myself an evidence-based medicine nerd, and the original authors who came up with this term, Sackett and Rosenberg, I think, they said evidence-based medicine means using the best available scientific evidence along with your own clinical expertise and along with understanding patient preference and your patient's values. Bringing those three things together in the best way is what they originally defined as evidence-based medicine. And there's this other group of authors. Jerome Groopman is the main author who wrote this amazing book that I love called Your Medical Mind. And they talk about how to understand patient values in more of a three-dimensional space. Where they say some people have values that are more aligned with using natural interventions. And some people are more aligned with their values with using technological interventions. Some people are minimalists. They want to do the smallest number of things possible, and other people are maximalists. They want to do the most number of things possible. And other people are skeptic by nature, and they just want to challenge whatever their clinician is telling them. And other people are believers by nature. They just want to believe and trust in the authority of the clinician who's taking care of them. And understanding where you are in this three-dimensional space is really helpful for understanding how to best proceed with choosing care that's in line with your values. I really recommend that book, Your Medical Mind. And they only talk about these axes, but there's another one that I see in my patients that I'm going to talk to you a little bit about later. And that means being cautious or being bold. Some people want to shy away from anything new or not completely tested, and other people want to embrace things that could bring them benefit, even if they haven't been tested very thoroughly. And knowing where you are in that dimension as well, I think, adds a lot of value to how you approach your own care. So, what is science-based care for IBD to us? Our goal is to present the highest level of in-context scientific evidence regarding medicine and IBD while harnessing our own experience and acknowledging the importance of patient preference and your health aesthetic. And that's how we're going to approach this course.